Allow me a moment to introduce our platform ClearNet. It is India's most trusted live digital CME platform, which allows doctors to create their own medical content. And I would like to take this opportunity to welcome the master doctor here today, also an eminent. Dr. Amitav Banerjee is a renowned epidemiologist and public health expert, currently serving as Professor Emeritus in the Department of Community Medicine at Dr. D.Y. Patil College, Pune, India. Thus, we are honored to have such a renowned expert with us today to share his insight on the topic tuberculosis control strategies, example, DOTS and NTEP. So, before going into the session, let me take you through the brief description of today's topic. TB control strategies aim to reduce TB incidence, transmission, and mortality. A cornerstone approach is a directly observed treatment. Short course strategy NTEP incorporates digital tools, active case finding, drug resistant management, and private sector integration. It also emphasizes preventive treatment and community engagement. Together, DOTS and NTEP represents comprehensive evidence-based frameworks crucial for controlling and eventually eliminating TB at national and global levels. So now, without much delay, I would like to hand over the session to you, sir. Please proceed with your talk.
Thank you, Rimpa. And it's always a pleasure to come on the Clarinet platform to share my views and also educate myself. Today, we'll be discussing about a major public health problem globally and particularly more in our country, because our country, we contribute almost 26% of the TB burden. So I would just briefly go through the points to be covered. We will just briefly discuss the public health burden, natural history of infection, epidemiological factors. Most of you, being doctors, will be aware of it. We'll run through this rapidly. Then, what are the government strategies? And what I would be stressing on is the challenge of multi-drug resistant and extensively drug resistant tuberculosis. And recent examples, case studies, how we had a problem of drug supply last year. And of course, we'll be talking, when we talk of multi-drug resistance tuberculosis or extensive drug resistance tuberculosis, the early diagnosis of these resistant types is important. And I will be going a little ahead and what is the current literature, but which is what is going to be the way forward to overcome the limitations of current diagnostics in coping with multi-drug resistance and extensively drug resistance tuberculosis, because I'll be just touching on this thing a little more and illustrating this with a couple of case studies in which the delayed diagnosis of multi-drug resistance tuberculosis can pose a hazard to the community. And it can also spread these strains and increasing the burden. And newer techniques of diagnostics, I'll be touching on it, its application in helping us cope with the multi-drug resistance. That is whole genome sequencing. That is the way forward. So I'll be stressing on this thing a little because it's a novel thing. And as we all know, that leading cause and globally about 1.5 million deaths every year and 7.5 million newly, that is the incident diagnosed cases. And India contributes to 27% of the global burden. So I was a bit concerned on this. I thought that maybe we have a large population. But I had a comparative with other countries, the top 5 countries which contribute over 56% of TB cases in the world. India is 26%, number one, followed by Indonesia, 10%. Indonesia is a very small country. And China is 6.8%. So we can compare China with India, comparable population. So we can see that we are far behind China in tuberculosis control. We are 26% we are contributing. China is contributing 6.8%. Of course, we don't know whether we can trust this data, but at least on Pakistan is 6.3%, Pakistan population is, I think, 1/5 or 1/6 of all population. So of course, I mean, all said and done, TB is a major problem in our country. And in India, 1.8 million develop TB every year, of which 0.8 million are smear positive. These are the positive cases. And every day we lose 1,300 people from tuberculosis. So it's definitely a major public health problem. And most of you are aware of these about tuberculosis, the infection. It can be people can be exposed without catching infection because it's a complex disease. The host factors also play equally important than just exposure. Then we can have infection without tuberculin conversion. Then tuberculin conversion without disease. Many people, because we are giving BCG universally at birth, so there will be tuberculin conversion without the disease. So tuberculin is not a very sensitive and specific test. Disease without signs and symptoms. So asymptomatic. Disease with signs and symptoms but sputum negative. Disease with sputum positivity. So there are different permutation combination. And another thing in tuberculosis is we were taught traditionally as the infection does not equal to disease. 1/3 of the global population are carrying the tuberculosis bacteria in the body, dormant stage. In India also, more than 33%, 35% of us are being infected and we are carrying the tuberculosis in a dormant stage, bacilli in our body, mycobacterium. And in times of lowered immunity, in times of stress or malnutrition or alcoholism or HIV infection or comorbidities or diabetes, many people can have a reactivation. About 5 to 10% will get the TB disease. 5 to 10% of those who are carrying the dormant mycobacterium in the body. So host factors are perhaps more important if or as important as the infection. So which we all know, acid-fast bacilli exposure to kill by survive freezing, can survive in dried sputum pus for many months. Important for transmission. Reservoir, that is the source, man is the principal reservoir. Open case of tuberculosis means the person who is coughing out mycobacterium, positive case, they are known as open cases. That person is infective and he can infect about 10 to 15 others. In fact, he may not necessarily get the disease. Then there is an extra human source also, mostly animals, including cattle, cows, which are very close in rural areas to people. The livelihood may depend on cow. So reservoir of bovine tuberculosis, mycobacterium, so that can also infect humans. And milk is a source of bovine tuberculosis for man. So unboiled milk, or so it can be. So therefore, we cannot think of eradication because eradication, this it's a complex epidemiology with subclinical cases with extra human reservoir, and no vaccine works. I mean, whatever vaccine we have got BCG for 70 years, in India, it has got been shown to have a very low efficacy because so many of us are as it is infected with the mycobacterium, but still we get TB. Still there is no robust immunity after infection. Nature has not given that. So the pathway of immunity is very complex, whether it's mostly cell mediated or humoral or a mixture of two, or like in malaria also. Therefore, challenge of vaccine. Many vaccines are under trial, but from past experience in our country, BCG has not proven itself. Mode of transmission, we all know, droplet, it's a respiratory infection, droplet, cough and poor, and the environmental conditions with poor hygiene, overcrowded transport, overcrowded homes, overcrowded workplaces, they all contribute. In fact, the developed countries, the tuberculosis came down before the anti-tubercular drugs were invented by improving in standards of living, by improvement in nutrition. Nutrition had played a very important role. And now again, we are coming back full circle for all TB patients are given some extra nutrition. There are government schemes are there. There are people who are volunteers who adopt a TB patient. So all this improve the host resistance by good nutrition. It's basically a disease of poverty, disease of poor living conditions, poor working conditions, malnutrition, alcoholism, diabetes is again a risk in poor as well as rich, and HIV infection, of course, co-infection. Incubation period is very difficult because, as I said, you get an infection, you may develop later in life after many years reactivation. But just for conversion, it's about 4 to 6 weeks to show that yes, the person has been infected. That infection does not equal to disease. Disease may occur after years, may several years. So it's not very easy. So primary reaction, we all know, primary childhood it occurs. Gons lesions, initial primary focus, draining hilar lymph nodes, healed by scarring and calcification. And occasionally, due to poor host defense, may give rise to complications like hilar glands may expand and block airway, bronchial tuberculosis, dissemination, TB meningitis, miliary TB in vulnerable children. So they say BCG protects against these severe childhood TB, but then again, it's not a very robust protection. It is about 27%. So BCG particularly has been a disappointment in our country. And in some other countries, it had been 80% protection, like South Latin American countries. But in our country, there are many hypotheses. One is that exposure to other mycobacterium interferes with the immunity given by the BCG vaccine. That's why earlier they used to give at 6 weeks, or uh, now they are giving it at birth, BCG, so that before the child is exposed to other mycobacterium. That is one hypothesis. So, but still it is been a disappointment. So these are the primary lesions in the lungs, and then it heals. So I'm not going into detail. I think the chart is also not very clear. Pathophysiology, it heals, and the foci may remain in the body. And the child tuberculosis is the hilar lymph nodes plus a peripheral lesion which calcifies. That this whole set complex is known as the primary complex. The hilar lymph nodes enlargement and a calcified peripheral subpleural healed scar. And secondary reaction, this is occurs in adults. Reactivation, it can be either by reactivation or the adult gets a fresh exposure. So it can be both. So for reactivation, basically it is the breakdown in host resistance. Maybe due to malnutrition. Many elderly people get TB because they are staying alone, they are neglecting their nutrition. There may be consumption of alcohol, old age, may overall immunity comes down. Steroids or diabetes also can reactivate tuberculosis, pregnancy, or HIV infection. So all HIV patients have to be tested for tuberculosis and vice versa. All tuberculosis patients have to be tested for HIV. Massive destruction of lung parenchyma and cavitations, mostly in the upper lobes. And clinical features may be loss of weight, anorexia, evening sweats, evening rise of temperature, cough, hemoptysis, dyspnea, chest pain. So these are all of you must have experienced. Then pulmonary, pleural effusion, pneumothorax, hemoptysis. Extrapulmonary, today we are basically concentrating on pulmonary tuberculosis, but it can affect any organ. And if it is widespread, it is known as miliary tuberculosis. It may cause TB meningitis, CSF we have to do, the osteomyelitis, renal tuberculosis, genital may be a cause of infertility in women, salpingitis. Then it can affect the skin also. So control is case finding and treatment. And mostly for when we started 1962, I think National Tuberculosis Control Program, and in the initial years, or even for quite some time, we were doing passive surveillance. A person coming with cough for more than 2 weeks, his or her sputum was tested and all that. Now, as we are going for TB Mukt Bharat and National Tuberculosis Elimination Plan, we are gradually going towards from passive surveillance to active case finding from the patient, his contacts or her contacts, or in the community contact tracing. Of course, it will involve a lot of fear. Preventive vaccine, as I said, BCG vaccine is not effective in India. And they are again trying for uh, trials again for as a booster dose in adults above 18 years. So in India, there are many centers, many states, the trials are going on. BCG among the vulnerable people, those who are alcoholics, those who are diabetics, trials are going on of protection of BCG vaccine, which has not worked earlier, but again, they are doing it on a pilot basis. So we don't know how well it will serve now in adults, because theoretical, one of the hypotheses was that exposure to other mycobacterium. Therefore, you are giving it at birth. But now once you are giving to adult, the adult has been exposed to many mycobacterium. So it is hit or miss, I think, this trial. But there are a couple of 3, 4 other vaccines which are in phase 3 trials, newer BCG vaccines. Then this improving the non-specific factors like improved standard of living and nutrition and housing. They are also very important. And now again the trend is towards improving the host resistance by good nutrition, good living conditions. So case finding, as I said, cough with more than 2 to 3, 4 weeks duration, continuous fever. So they are subjected to sputum examination. That was the traditional 3 samples early morning, and then molecular tests are very important now. GeneXpert, CBNAT, and TrueNAT. These are the tests which are mostly available currently, but as I will emphasize, they have got the limitations, particularly in control of multi-drug resistance tuberculosis and extensively drug-resistant tuberculosis. Chemotherapy, we know these are the first-line drugs, rifampicin, isoniazid, streptomycin, pyrazinamide. These are the bactericidal, ethambutol, and thiazolone. And they are second-line drugs. I am not going to clutter the presentation here. So, but there are a number of second-line drugs. There are more than 18 second-line drugs. And the latest to come in India is bidoculin, and then protein managed linozolid, that is given in extensive drug resistance. So we'll be discussing briefly about those things. And we know the 2-phase chemotherapy. First phase is short, aggressive, intensive phase, 1 to 3 months, which are 4 drugs combined, at least 2 preferably bactericidal drugs. And then second phase is 2 drugs, rifampicin and INH. So first 2 months, and then subsequently 4 to 6 months. So these are the 2-phase chemotherapy. We are all aware of it. DOTS, directly observed treatment short course. This was started in 1995, I think 96, where the compliance and drug was not there. To ensure that the patient is taking the drug, health worker or other trained person watches as patient swallows the drug during the first phase, the intensive phase. During continuous phase, patient is issued medicine for 1 week in a multi-blister combi pack, of which the first dose is swallowed in front of the DOTS agent. And when he or she comes for the refill, they have to bring the empty blisters just to ensure. So DOTS this is a directly a treatment short course. We all know about it. And then BCG vaccination, as I said, it was earlier given at 6 weeks, but now they recommend to be given at birth. But the efficacy is not very promising as on today with the present vaccine. Then revised National Tuberculosis Control Program 1994, achievement of not less than 84% cure rate and detection of the 70% of the estimated cases. How you estimate the cases? As on today, let us say the incidence is from the present figures is in India per lakh population every year there are 132 new cases. So depending on the region, health officer of a particular region or an administrative officer or a tuberculosis officer should estimate what is the population of her district. If it is say 5 lakh population of a small town or a village, small town 5 lakh. So for every lakh there are 132 cases. So there must be about 600 cases or something like that, 5 to 600 cases should be detected in a year. So if it is a estimate is say 600 depending on the population and at the rate of 132 cases per lakh. So you have say 600 the estimate comes depend. So at least 70% of 600 you calculate. So that is the detection at least of the estimate cases. And out of this, they should be put on treatment, appropriate treatment and achieve 85% cure rate. And involvement of private practitioners, involvement of non-government NGOs and DOTS program. The Stop TB strategy, then in 2006, the Stop TB strategy was adopted, high quality DOTS expansion, address TB, HIV, multi-drug resistance, tuberculosis and other challenges, health system strengthening, engage care providers, empower patients and communities and research. So these are the domains for Stop TB strategy. Then 2015, again, it was the strategy was to integrated patient-centered care and prevention, bold policies and supportive systems, research and innovation, and 90-90-90 targets. That is reach, detect, and treat 90% of TB patients. In that, what we saw was to find out 70% detect. Here, we are more ambitious. In 2015, Stop TB strategy made the target that we should be able to detect 90%, achieve 90% treatment services, that 90% of them are put on treatment, and reach 90% of vulnerable, underserved, at-risk population like contacts, slums, migrants, HIV patients, etc. That is the active surveillance component. Then TB elimination goal clarion call by PM on March 2018 to achieve TB Mukt Bharat by 2025. So that was the call given by the PM, whereas WHO has called for 2030, but we were more ambitious with 80% reduction incidence compared to 2015, 90% reduction in deaths as compared to. Then zero out-of-pocket expenditure. These were the very ambitious targets given in 2018, but unfortunately, the promise was something, the practice we failed because of some logistic problems. We'll be discussing that. Then there's a surveillance and monitoring using the digital platform NICSI portal, where it was launched in March 2018, a compulsory notification, call center NICSI Sampark, where the TB patients could be reminded of missed doses, they can be contacted, physical proforma and district nodal officers, they all came into. And then, as I said, community involvement, as Rimpa mentioned in the beginning, community involvement is important. So TB Mukt Panchayat initiative was started in March 2023 by Government of India. Healthy village for healthy nation, as envisaged by your father of the nation, and using the Panchayat Raj system to achieve TB goals by 2025. For villages to obtain TB-free certificate valid for 1 year, first two indicators to be achieved, more than 80% units under the Panchayat, at least 3% of the other indicators to be achieved and to be verified by a team of district level involving health department. So involving the panchayats and giving them some targets and some certificates for good TB control. So then of course it had its weaknesses, lack of periodical monitoring, overemphasis on certification and award. That becomes an unhealthy competition, lack of panchayat level TB surveillance data, lack of robust evaluation which can compromise sustainability, budget heads for planning not specified. So we make the programs, but until unless we work on the finer details, the program remains on paper only. And the huge gap, I mean, just to bring out how much Just making it on paper doesn't work if we do not give the service, we do not supply the drugs. So in March 2024, there was a prolonged, starting from March 2024, for 4 months or 6 months in many parts of the country, there was a stock out of TB drugs. So you see, this is something which is very, very disappointing. And there was a letter from the Director General Tuberculosis, Ministry of Health, that procurement process of drugs and diagnosis completed, but due to unforeseen reasons, supplies may get delayed. It also added that local purchase at state and district level may be resorted for 3 months so that patients do not interrupt treatment. Budget of National Health Mission can be utilized for this. So a letter was given to local authorities to purchase it. It also made provisions for reimbursement in case patients pay out of pocket. One of the was that poor patient, they don't have money for their daily food. So and then the provision was made ki they can buy the pay from their pocket and it will be reimbursed. So one can imagine the long process, the reimbursement, the documents, and at least the district authorities may have purchased. So ground reality, we have done, some of our colleagues have done study. So they gave the feedback, the TB drugs were not available, at least in Maharashtra, in Pune district. Despite clear instructions, TB drugs were available, were not available for TB patients in many states for months, from March to July 2024, March, April, May. March, April, May, June, July. For 5 months, there was no TB drugs available in many states. Some rural areas continue to have TB drug shortage. Or TB patient faced financial, that was beyond July. I mean, few months beyond July. Now means this I had written some time back. TB patient faced financial problems due to out-of-pocket expenditure. Many patients tend to drop out. As it is, see, we are making so many efforts. On one hand, we want to directly observe treatment, and then the health worker or the health personnel have to counsel the patients on not to drop out, not to miss any dose. To that extent, we are trying to counsel. And when they can't supply the drugs, what impact it makes on the patients. And when there is a shortage, they come. In normal course, you may give the drugs for 2 weeks to come after 2. But when there is a shortage, you may give for 4 days or 1 week. The patient has to make more trip, loss of wages, transport cost. So there is no moral authority for that health staff to ensure compliance in the patient. When the drugs are, I mean, this requires, you see, many programs failed, including the malaria eradication program, because of this logistics problem, administrative problems. And then if a 5 months drugs are not available, a short course treatment is for 6 months. So majority, there will be incomplete treatment, and you will be promoting multi-drug resistance and extensively drug resistance tuberculosis. You are creating it. Drugs given for fewer days to patients have to make frequent trips. So these are some of, I'll be giving the reference of this. Consequences of TB drug stockouts. It is challenging to ensure, as I have already, if drugs are not available, how can health worker have moral authority to insist on compliance? Short supply, as I said, drug resistance tuberculosis. Patient suffers and also spreads infection in the community, including the, so you are increasing the burden. And this was in 2024, and the target was 2025, the Bharat Mukt TB. TB Mukt Bharat. TB Mukt Bharat, the target was for 2025, TB Mukt Bharat. There will be no tuberculosis in India. And if in 24, for 4-5 months, the drugs are not available, essential drugs, I mean, it loses the credibility. So this is the unfortunate part. Challenges for, so this is one aspect that we have the technological solutions, we have the drugs, but we should also have the good administrative backup, good logistics. Then challenges are drug resistance tuberculosis, important channel, rifampicin resistance or multi-drug resistance tuberculosis and extensively drug resistant tuberculosis are greatest predictors of poor outcome. The success rate of multi-drug resistance is just 60%, 68%, 60 to 68, whereas for susceptible to drug susceptible tuberculosis above 80%. And the cost is very high, many times more. Cost and number of drugs, second line drugs, side effects are more, duration is more. So it's a lot of cost to the state, cost to the individual. One multi-drug resistant TB case can infect 2.6 secondary cases. So it spreads in the community. Timely diagnosis and treatment of drug-resistant tuberculosis can interrupt this chain of transmission of multi-drug resistant tuberculosis. The National Tuberculosis Elimination Program has mandated universal drug susceptibility test. This is very important. I am coming to a very important as a part of the presentation, that is the uh, drug susceptibility testing and how much we are limited in our present methods. The limitations in drug susceptibility testing with existing methods. The tests available for drug susceptibility testing are variants of the PCR test. This one is cartridge-based nucleic acid amplification test, CBNAT, line probe assays. These are the state of art till some time back or today perhaps in many parts. The cure rates among multi-drug resistance or rifampicin-resistant TB and pre-extensive drug-resistant TB started on second-line treatment in India in 2021 was 73% and 69%. So this is the rate in India, cure rate of second line treatment. Whereas in other countries like Peru and Latvia, where there is individualized treatment instead of a protocol, like we have a protocol, the person is subjected to CBNAT and you get that yes, you register and you put on a set of second line drug. And where individualized treatment is provided, the cure rates were above 80%, almost matching the. So we'll see the reason that it is due to the limitations of existing methods of diagnosing drug sensitive, drug susceptibility, diagnosing drug susceptibility test. Over the years, many methods have evolved for identifying drug-resistant TB. However, they have the following limitations. Culture. We had a traditional culture which used to take 2 weeks to 8 weeks to get the results. And in the 8 weeks, the patient is having the bacteria unattended, inappropriate treatment or no treatment. So it was not of real time. Liquid culture 10 days, but failed to detect clinically significant resistance in certain rifampicin-resistant TB cases. You see, we are a first-line drug. The strongest is the rifampicin and isoniazid, of course. Then came the nucleic acid amplification test like NAT, such as Expert and, as I said, CBNAT. And these require stable electricity and technical expertise in case of line probe assays. These are variants of this PCR. Other limitations are, this is the last sentence is most important. Other limitations are that this test based on nucleic acid amplification can only detect rifampicin resistance, only rifampicin resistance. Because second line drugs, there may be many second line drugs which may be offered to the patient, but it may be having resistance and the time is wasted in giving the correct treatment. Now, there is a method now which is coming up, that is whole genome sequencing. And what are the advantages? It can detect known genetic determinants of drug sensitivity, can provide drug resistance profile of 18 anti-tuberculosis drugs, 18, 1-8, more rapidly, is affordable and accurate. So you see, up till now, this CBNAT and other line probe assays, they were only giving the profile for rifampicin resistance, only one. There are so many TB drugs in second line drugs, it was not giving. So you do the CBNAT or line probe assay, you find rifampicin resistance and immediately you go to second line treatment, whatever the protocol, 4 drugs, 5 drugs, whatever, and continuation. Without knowing, it's a shot in the dark, without knowing whether the strain is resistant to these second line drugs. So if you have something like whole genome sequencing, WGS, you get a profile of 18 anti-tubercular drugs, and from that you can choose the second line treatment, customize it for each patient. Now, two case studies I will be presenting. Is my colleague, Dr. Sachin Atre. I am just, he has got two case studies he discussed with me a couple of days back, and he is trying to publish it in some journal. So I just took his permission as an illustrative case study. I mean, it is to be peer reviewed, but this is just to stimulate the thinking of the learned doctors. So these are two case studies to illustrate this advantage of the whole WGS, whole genome sequencing. First case is of a young girl, 21 years old, we diagnosed in January 2018 with tuberculosis. CB-NAT results indicated rifampicin susceptible. You see, this can also mislead. CB-NAT indicated that the girl is susceptible, there is no rifampicin resistance. And then you assume that she can be given first-line drugs. It is not MDR. So therefore, she was put on first-line ATT. She did not respond to treatment, was shifted to bedaquiline-based therapy to which she responded well. You see, again, you are hitting in the dark. However, in July 21, she was again positive, sputum positive, acid fast bacillus positive with CB-NAT results, and again rifampicin susceptible. By this time, whole genome sequence was available, which showed she had pretty extensively drug-resistant tuberculosis. So it was very late. After nearly 4 years of inappropriate treatment with one completely damaged lung, she succumbed in August 2022. So we lost time. And she was in between put on bedaquiline. Another problem with bedaquiline is that bedaquiline has got a long half-life, almost double the half-life of the other anti-tubercular drugs. So what happens is, even if you give polytherapy with bedaquiline, other are washed out, other drugs, but the bedaquiline remains for longer duration. And during that longer duration, beyond that, it is acting as a monotherapy, and the drug resistance to bedaquiline also develops. So this is the challenge. So this is the first case which the patient succumbed. Now, this is the second case. A 27-year male detected with TB, and the CB-NAT indicated rifampicin resistance, and his sputa samples simultaneously subjected to whole genome sequencing. The resistance profile indicated that he was infected with extensively drug-resistant tuberculosis, but it was susceptible to ethambutol, crepomycin, kanamycin, amikacin, PAS, bedaquiline, clofazimine, dilaminate, and pretomanate. So it gave a complete profile of susceptibility of which drugs will work. It was evident that an empirical multi-drug resistance MDR regimen, multi-drug MDR regimen would fail. So he was switched to individualized treatment. So initially, look, he was found rifampicin resistant. In normal course of thing, he would have been put without the WGS whole, he would have put on the routine. But now we had a profile of the drugs to which he was susceptible, and from these drugs, the second line was chosen. It was evident. He showed good improvement with a weight gain of 22 kg. His sputum treatment was consistently negative and was declared cured. So this is the time save, and it is not only saving the time. If you prolong it, the person is a hazard to the community. He or she is spreading around. So it has got a clinical significance. It has got a public health relevance. So this is the diagrammatically of the two cases. You see the flow diagram. I don't know whether I will be able to show with the pointer. I don't know. So this is the case one, that the person comes and it is found not detected, and by the time I don't know. I am not able to use the pointer. Anyway, I see if you can make out TB diagnosis in 2018. I have already given the sequence. It is just the failure to detect. And by the time the top case, you see the long chain of trial and error in between starting bedaquiline, and then by the time one lung is gone and the patient succumbs. Whereas in the second case, it is a open and shut case. The patient is immediately on the first contact with the sputum sample. Sputum sample shows with CB-NAT rifampicin resistant. And simultaneously, the whole gene sequence showed the drugs to which the patient would respond, susceptibility. So once you get a susceptibility profile, you choose the drugs from that only, second line, instead of just hitting in the dark and prolonging the patient's disease and infection and transmission to the community. So the first one was just hit and miss, only on one clue of you get only the most prevalent test like CB-NAT and nucleic acid amplification is based on one rifampicin, whereas here you get a profile of 18 drugs. So definitely whole WGS will help us cope with the multi-drug resistance tuberculosis. And the cost also I tried to find out. I think it is 6,000 compared to 2-3,000 with the other methods per test. So, but you may save in the time, you may save in the duration of treatment. So the cost to the individual, the cost to the state or the community would be, it can compensate many times more, firstly. Secondly, with the artificial intelligence coming up, you can, I think, it can more rapidly do the whole gene sequencing once it gets on that platform. I mean, these are the way forward, the future possibilities. I am just loud thinking, and it may do it rapidly. And that is, I think, what is going to be precision medicine. And it is definitely required in tuberculosis, precision medicine, particularly to cope up with the extensively drug resistance tuberculosis or multi-drug resistance tuberculosis. So this is the conclusion. Control of TB has many challenges. TB treatment requires multiple drug regimes and combinations. Good management and logistics is essential to ensure uninterrupted supply of drugs. With challenges of MDR and extensively drug resistance, one should rethink introducing near diagnostic modalities like whole genome sequencing. This is the most important message I wanted to convey today. I hope you will appreciate it. And these are some of the references which you can see about the drug stockout, and the whole gene sequence is not, I have not documented it because it is still under publication and with special permission to, I found this very interesting for illustrating the whole gene advantage of WGS, whole gene sequencing. So that's why I just wanted to use those examples. Thank you so much.
Thank you so much, sir, for the comprehensive talk. So, sir, we have received some questions. So, may I have your permission to share it?
Yeah, please.
Okay, sir. Just allow me a moment, sir. I hope my screen is visible, sir.
Yeah, despite implementation dots, higher TB burden globally. What other? Yeah, this is a very good question. I think it covers up what I had missed out, perhaps. Because dots, efficacy of dots under experimental conditions was, the outcome was very good because one could monitor the patients, one has selected the patients, taken the consent, and directly observe. But in real life, there are many factors, the social factors, the environmental factors, and the program barriers. So the social factors, the most important are in large cities and urban areas, a lot of migration. The person is here and then the person moves to other city. Ideally, their records should go to the next dot center. But Patients may not be after 2 months, 3 months, they feel better, they may discontinue. And then we have the program barriers as illustrated in 2024. We had the outage, stock out. We had the stock out of anti-TB drugs. So these are the barriers. That's why I was saying, at least from the administrative point of view, institutional point of view, we should ensure the availability of TB drugs. And then, of course, the resource crunch in counseling the patients and the importance of continuing the treatment even after the patient is asymptomatic. And DOTS, it is first intensive phase only. It is under supervision. The person takes the medicine. Subsequently, the only the first dose he is or she is giving the blister pack. So the supervision gets a little diluted even in DOTS also. And as I said, under experimental conditions, the results were very good. But in real life conditions, there are many factors. As a social is a communication gap between the health personnel and the patient. Their country has got migrant population with different languages, different comprehension. So all this adds to the burden in our country. Given the social impact, how should NTP evolve to include comprehensive social protection strategies beyond nutrition and travel support to ensure long-term? Yeah, this is also a good, important factor. Many people are poor, and TB makes them poorer. It affects their work capacity. It may affect their rehabilitation. So here the NGOs can play a part, and philanthropists, corporate social responsibility, they can be included to provide some long-term and building. I mean, we are again going back towards the non-specific factors like healthy living, good nutrition, good housing. So we can think outside the box by involving the philanthropist and the corporate social responsibility for giving them some nutrition, housing, maybe employment also, vocational training also. So these are some of the things we can explore.
Okay, sir. So thank you so much, sir, for answering all the queries of the delegates. So, sir, we have received a case-based question. So may I have your permission to share it, sir?
Yeah, please.
Okay, sir. Just allow me a moment, sir. I hope my screen is visible to you, sir.
Yeah. Yeah, this is perfectly what we had discussed, that the patient, male patient, 45-year-old, he had a typical symptoms of tuberculosis and diagnosed with pulmonary tuberculosis using CB-NAT under the National Tuberculosis Elimination Program. And he was started on a daily fixed dose of the regime under the DOT strategy and monitored. So far, so good. So 80% or 90% of the times, the patient will have a good prognosis. Why was the key components also, and how do they have ensure treatment success? And provided this patient does not drop out, provided this patient has uninterrupted supply of drugs. As I said, and that last time in the last year, there was a drug interruption. And then provided, and of course, there are five components, as I said: the political commitment, the availability of drugs, the patient compliance. These are how close assigning a treatment supporter, improve treatment, and treatment supporter is very important. And a DOTS provider can be any volunteer, can be a school teacher, can be a volunteer, can be the ASA worker. ASA workers are there. And what is the next step in management of the patient under National Tobacco Elimination Program, and how does the program address drug? Here, the third point is the limitation. In this case study, you said the patient was diagnosed with CB-NAT. And as I discussed in my presentation, CB-NAT only detects the rifampicin resistance. It does not give the profile of other drugs. So suppose the patient is resistant besides beyond rifampicin to even the first line drugs, they may likely be treatment failure. So otherwise, as on today, this is the gap in the program as on today. And for that, I have just done loud thinking that we may, the way forward to ensure that drug resistance tuberculosis problem is also addressed, we may have to go for whole genome sequencing. Thank you.